how many minutes is it gonna take me to get back to the baseline? 2.5. And actually, because it takes a little bit of a slow start, it takes more like 3 to 3.5. So we'll show you that next. So when we show this demonstration to physicians, we're showing it to them, not because we want to beat up on Trilogy, because it's a good machine, but its intended use was chronic disease state management. If you walk away from an ALS patient today and they change over time, the machine is going to reset the baseline over time. But if the patient dumps, like the patients we're talking about, it's not equipped to chase that patient. Most likely that patient's going to go back into what we call homeostasis by doing the work of breathing. So you have maybe potentially half your patients not getting the full benefit of these devices. So I'll turn it on. Now what I did with this thing is I set it up exactly the same way. And it may take a minute. You guys had it in AE mode. First of all, I have it set at 15/5. Sorry, I forgot your name. Ryan. Am I going to 15 or where am I going to?
18, yeah, around 18, 19.
It's set for 15/5. Why it does this, I can't explain to you, but I only learned this as I started doing this demonstration. When I put it in AVAP's AE mode, it learns for the first 50 breaths, and it overshoots your set pressure support by about 5. So sometimes I see 20, sometimes I see 22. Right now I'm seeing 19. It will go over 50 breaths. It will breathe its way back down to 15/5. It's really, I don't know why it does this, but it's really awkward because when you put the machine on, like CPAP, what do we tell them to hit? Ramp. We're actually making the machine go higher than what their baseline need is for 50 breaths to get comfortable so the machine can learn some stuff. And so, I don't know why it does that. I asked people and I get different answers. So once it gets to 15/5, we kind of close?
Yeah, right there.
All right. I'm going to do the same test. I'm going to squeeze. If you don't know what I'm squeezing this little tab against here so that I get the same exact resistance. If I squeeze the lung, I can cheat. So, keep me whole here. It's not showing tidal volume. Guess not I see the tidal volume. There it goes. We're like 4 or 5 breaths into this deal. Let me see.
What's your tidal volume?
I don't see it. There we go. Exit.
Now, is this when the tube will do that vibrating you were talking about? As well?
Yeah, about 5 minutes. It takes about 5 minutes for it to go through. See tidal volume yet? Doesn't matter. I'm only
right there.
Yeah, where was it at? That's set tidal volume.
Oh, I'm sorry.
Put it this way. After about a minute of blabbing, I'm only at 17/5. It only went up 2. It really takes till it gets to about 22/5 before it actually gets them anywhere close. Sometimes 25/5. Exit. Exit. I don't know how to get into this stupid menu. Who said this thing was easy to use?
Where's your home button?
I hit it already. I hit the exit button 3 times.
It's not
What's
working.
this one?
I don't know. I can tell you right now, it's not there yet.
Yeah, I saw the demo this morning. It's probably hanging around 250, 270 right now. I mean, it took, someone went to the bathroom and came back and it was still working, catching up.
Bluetooth, my settings, options, alarms, information, select. Bluetooth enable, Bluetooth discovery. Back to the again. There we go. Sorry guys, I'm not a Trilogy expert.
Are you just looking for the display?
Yeah, just
Yeah.
the tidal volume on the screen.
Yeah, I do have them here now. Come on, Jeremy,
Well,
come
let's see. It
on.
doesn't mean I'm going to remember exactly what we're doing.
I got to there, and I go to there, and I think it's stuck in the clinical mode.
Yeah, that's right.
And I keep
So we
exiting
just
the
wanna
clinical
go-
mode.
Yeah, everything is.
Well, don't we just want display, right?
Yeah, go display.
So I think we go my side. No, that's not right. Options.
I should make a race on you guys setting mine up versus setting theirs up.
Yeah.
Because I think I'd win that too. You guys are all iPhone savvy.
He also does spark plugs too. If you
Yeah.
Actually, I'm gonna
Something's
say it's done because it's kind of baselined about 25 centimeters of water pressure, which is about where ours went to. So I don't know how long did that take. But the point is, it's pretty dramatic, right?
Yeah, but something it looks different than it
It
normally
does look
does.
different, doesn't it?
Well, what mode do you have it set in?
It's AVAPS
AE?
If I let it sit here long enough, it will start pulsing the airway to check for compliance, and you'll see the test line go like this, all flutter, and you'll hear people complain about it. It's just the technology that they're using to check airway patency is fairly old. They don't even use that anymore in their CPAPs, I don't think.
They do that P optimal, P critical search.
Yeah, but do they still do this? Do they still vibrate every? This thing goes pretty. It's pretty
I don't
hefty.
think it's like exactly.
It's
like
a
that.
centimeter of water above and below the baseline.
Mhm.
So it's going a full 2 centimeters of water pressure up and down like this. And it doesn't do it in sync with the
2
breath.
centimeters for a second and a half.
And it doesn't do it in conjunction with a breath. It just keeps
does
doing it.
randomly. Yeah.
It can be really disruptive. Anyhow, is that helpful to see that? I don't know if it is or not. Like I said, it's not to beat them up, it's just to show you the differences. So if you have this patient who looks,
So basically what you're saying is there's a faster recovery time for these patients as they start to go down that slippery slope
With the Astro.
with the
With the
asthma.
Astro.
yeah, so here's the deal.
Proportionate.
Here's a slippery slope. This article came out. Whoops. This article came out in May. Where'd it go? May of last year. Okay? And this is just a snapshot of these patients under PSG. Every patient in this study were hypercapnic respiratory failure patients that had recently exacerbated. They took those patients to the sleep lab, which is, we don't want to do that here. This is in Japan. They put them in the lab. This is what they saw. Each one of these little dips is their oxygen levels every time they go into REM sleep. Every one of these little peaks is their CO2 levels every time they go into REM. And the duration of these are really, really short. So what's interesting is if you guys have read any of the literature at all, why NIV? It's because if you look at all the studies done 2014 to present, hot HMV, cone line, all these, they basically say that you're going to reduce the readmissions by about 50%. You're going to increase mortality by about 50%. So, which is a great thing in that you can talk to somebody and say, you have a 50% better chance of being alive at 1 year if you wear this thing, right? That's fantastic evidence. And there's 3 articles that really support that, and they're very clear on it. This article came out and looked at something unique. It looked at those same 2 factors, but it also looked at serum albumin levels. It wanted to see, it knew these patients were really severely malnutritioned because I use this analogy with Damon because I know he works out all the time. If you were on the treadmill doing an interval and you get to that point where you're like, I'm going to throw up. Imagine trying to eat a cheeseburger. How do you eat it? You can't physically take it in because you're working so hard to get air in and out of your lungs. You can't eat anything. They're working so hard, they can't eat anything.
Well, and their muscles burn calories.
And they're burning calories like crazy.
Just to breathe.
So they drink a lot of insulin. When they put these patients on IVAPs, because it was the only algorithm of the 3 units that in this space that could actually treat a patient that rapidly changes, this is what they looked like in PSG. That's good. That means we stabilize their ventilation patterns so that they can get in and out of REM without any disruption. What happened was their serum albumin levels came up 13% over a 6-month period. They were more vibrant. They actually had life. They actually had better quality of life. They were actually eating, which means they were feeling better, which means they were probably doing more. And so it's the first article that I actually read of any of these articles that talks about anything other than just readmissions and mortality.
And you know what, Mike, part of our problem is our docs will put these patients on non-invasive, not in stage 3, but in stage 4. And And that's what we're trying to get them on in stage 3, get them earlier in the disease process. Don't just use it as a rescue to keep them out of the hospital, keep them from being tubed, but get them on earlier. So, and that's the battle we fight out there.
Does anybody know what's the biggest advantage of putting the patient on the ventilator versus putting the patient on BiPAP?
Being able to sedate them.
No, I mean,
You mean a
for
real
home
ventilator?
care. For home care,
Oh,
what's the biggest advantage of NIV versus BiPAP?
There's no rate, there's no volume, there's no minute volume going on.
All right, so
No volume
I'll give you. I think all this.
Blow it in,
That's
blow it
actually
out.
100% correct. So let me narrow it a little bit. Outside of the physical attributes of the device, what it actually does. What are the advantages of that versus a BiPAP? So not what it does. There's something else, and it's really plays to what you guys do.
It rescues the patient,
What do you guys do?
keeps them home.
You go to the house,
Oh, okay.
right? You partner with them in the home. When you sell them a bi-level, you sell them a bi-level. It's transactional. Hey, let me show you how to use it. Thanks for coming in. I'll monitor you and interview for 30 days. And if you're compliant, right? It's transactional. When you guys don't underestimate, especially for doctors like this who are like, you know what, they don't need it yet. They're not, they're half dead. What if you changed it and said to them, Doc, don't you think that patient would benefit from some respiratory intervention in the home? Wouldn't you love it if a respiratory therapist could go to that patient's house and partner with them and then kind of tie a knot in this continuation of care so that we have skin in the game in the house so that we can see what their home life looks like? Are they actually eating? Are they taking their NED meds the way they're supposed to? Do they have the right support system at home? Et cetera, et cetera. And if you want to call it BiPAP, just don't call it BiPAP so I can get a script, right?
Yeah.
So, but yeah, I get all this extra stuff that I don't get with the BiPAP. And of course you get a more complex therapy that does cruise control, which you don't get with a BiPAP. So yeah, you certainly have the modality, but more importantly, you have this thing that you guys can sell, and that is your program. That's your RTs going into the house. And I like the idea of, instead of calling it NIV, I like calling it respiratory intervention in the home.
Thank you.
Thank you.
Hello.
So, do you guys do a lot of oxygen?
Not so much. Well, yeah.
They do oxygen.
We do oxygen.
We
Yeah,
have
it's
customers
not our
that do
favorite.
Why is everybody so angry with the oxygen up here? It's like
It stinks. It's hard to get now, and there's no money. Yeah.
That's true. All right. You can actually mine some of those patients too, and you can say, hey, as part of my respiratory assessment program, we identified a patient that we got on oxygen who also fits, a criteria of somebody who could benefit for respiratory intervention in the home. Again, if you don't call it Trilogy, you don't call it NIV, it's just a springboard to get all these other benefits. And so when you look at, there was another study that came out recently. Did you guys hear about the KPMG study? Hey, for bonus points, who's sponsored by KPMG?
Bill Nicholson.
That's right. So KPMG looked at the financials of patient who came out of the hospital that exacerbated for COPD, so hypercapnic respiratory failure patient exacerbates. They cost healthcare $41,000, okay, a year on average. Put them on BiPAP, $39,000. There's a slight decrease in the overall cost. If you put them on a high-touch NIV model, $29,000. It more than pays for itself. Mm-hmm. And what do you think the difference in the cost is? Probably one exacerbation. That's quality of life. Right? So, Doc, hey, I know you believe in using bi-level for early intervention, but let me show you this. Financially, it makes more sense for those patients to be on the vent because it pays for itself. And if we keep them out of the hospital one time more per year, it's quality of life. It may be the difference between them going to see their, nephew play hoops or graduate or a wedding or whatever it is. That's quality of life for these people. And they have they're 50% less likely to be dead at 1 year. I mean, that's pretty good stuff.
Yeah.
But it's only coming with a high-touch interventional model, and that only comes with the ventilator because nobody's paying a respiratory therapist to go to the home and put them on a BiPAP.
Do you think that you could, I have a script, let me pass this down to you. Because the referral sources will always say